Hello, this is Mara, founder of Aunt Zelda's, and you are listening to Professionally Cannabis.
Where do they go, the smoke rings I blow each night?
Hello, listener, and welcome to the Professionally Cannabis podcast. For today's episode, we have an interview with a real OG in cannabis. Oscar, can you tell our listener who we had on the pod today?
Our guest today is Mara Gordon, who you may recognise from a phenomenally moving and an interesting film called Weed the People. Mara has been working in cannabis for an awfully long time, treating a variety of patients and taking care to start identifying specific extracts and ratios of THC and CBD to work with patients for given ailments. So doing the early scientific work that this field needed in order to really get off the ground. Now she's taken it far more pharmaceutical with a far wider scale, and listeners, I'm sure you're going to find it fascinating to hear more about it. So let's hear the interview.
Where do they go, the smoke rings
It gives me great pleasure today to welcome to the pod Mara Gordon, co-founder and CEO of Aunt Zelda's. Now, for those of you who don't know Mara, and I imagine there aren't so many of you, Mara is really what you can call an OG of the cannabis industry. And with that in mind, we cannot wait to pick her brains. Mara, great to have you with us on the Professionally Cannabis podcast.
Jonathan, I'm thrilled to be here with you today. Thank you for inviting me.
Welcome, Mara. And so, a question that you'll probably have to cast your mind back some ways for, but one we ask all our guests. What led you to the plant?
What led me to the plant, interestingly, was the fact that there were no solutions in traditional pharmaceuticals for myself or my husband in the medical conditions that we were dealing with. I've told this story before, but I don't ever want to stop giving credit to the young woman who led me to the plant, a woman by the name of Kay Cortopassi. I had considered her very unflatteringly as a stoner, using that pejorative sort of label for her. She would wake and bake. She would tell me about how she did this and used cannabis. And I didn't understand really that she was using it for harm reduction at the time because I didn't know really what that meant. But she came to visit me and I had sent her out to the garage to smoke her pipe because I didn't want that disgusting stuff in my house. But I went out to just keep her company for a few minutes. And I thought, what the heck? And I was in a lot of pain. So I asked if I could have a puff. And she gave me one. And I took a second one. And my pain went from about a level 8 to a 2, like almost instantaneously. And I thought, why has no doctor told me about this? That's just, this is so wrong to have allowed me to suffer and have such failure with pharmaceuticals ameliorating my suffering when this plant can do such a beautiful job of it without any harmful side effects. My husband at the same time had broken his back and needed to have back surgery. And at this point, he's now been sober 33 years. At the time, I don't remember how many years it was, but it was still more years than he was willing to give up to go down the opioid rabbit hole, which is where he would have had to go. And he said he'd rather be in a wheelchair than to go on opioids. And so we were able to do some testing to see if it would trigger the phenomenon of craving that opioids and alcohol do for many addicts, and it just didn't. And so it was a perfect solution for him. We embraced it. I embraced it, obviously in ways that now have become quite well known, and went seeking out lab tested products. And when I went to first get products, there was nothing there that was going to be informing us on how to use it and what to use. So it became quite clear that I was going to have to figure it out myself. And that's how I got started.
To follow up on that, how did you take what seems to be, I suppose, a patient perspective and turn that into the globally known business that we have today? Because that's quite a transition.
Yes, I mean, had absolutely no interest in going into business. And some people might say from the outside, I never actually have, depending on some of the way that some of these cannabis businesses have become these, ridiculously high stock values, et cetera. But, that all aside, commentary aside on that, what happened was when I started making medicine for us, there wasn't really any information available. I mean, there was a couple of forums out there. I think there was like THC forum where it was more of the old bulletin board style where people would, try to answer their questions and have conversations about it. But nobody even knew about decarboxylation and things like that at the time. They knew that you had to heat it, but they didn't really understand the temperatures. And I mean, there was just so little information. So I started just experimenting and making what worked for us. And other people started seeing the results that we were having with our lives and asking us if we could make some medicine for their loved one or their family member or friend, et cetera. And when I realized very quickly that the only way that this was going to be accepted by physicians was by having real data around what was working and how it was working and how to dose it and how to know how much and how often, et cetera. My only requirement for these people that I was making medicine for was that they give us feedback on how much they took and how it affected them with objective information as well as obviously just how they felt. I wanted to know if it had actually worked at a metabolic level to decrease whatever their suffering, what their condition was. So people that were like, okay, I'll make you medicine, but you got to give me the data. And that is really how it started. And I can't remember exactly. I want to say it was the fall of 2011 or late summer 2011. The first serious cancer patient approached me asking me to make medicine. And it turned out that his doctor had sent him to me. He'd heard about the work I was doing and sent him to me. And I was very concerned about working with cancer patients to begin with, because that's a tremendous responsibility, far beyond helping somebody with their sleep or pain. And, my consideration has always been working with physicians, not against them or behind their backs. So the fact that this gentleman had come to us, with the support of his physician, I was willing to help him and keep the conversation going on what we were using and how it was working and getting the feedback, and then it just became a matter of scale. Then I started training nurses. In fact, the first nurse that I trained is now the president of the ACNA. And I'm very pleased with what she's done to grow her career and help other patients and help other nurses to help other patients. And then I started working with physicians. I really do believe that physicians are the answer to global adoption of cannabis, because if they aren't prescribing it or recommending it and guiding it, then nurses who are more geared towards implementing what the doctor recommends are not going to be thinking quite so outside of the box. Most people depend upon their physicians for guidance more than their nurses, just the way our healthcare system works. But when I had enough doctors and enough nurses that were working to treat patients and we were getting the data, I then built a platform for the data. My background is a process engineer, so it's always about looking for consistency, patterns, repeatability, all those sorts of things that are part of in my DNA. And then other people wanted to be able to access the data and the information. So it kind of grew from there. And so I had to start each of the different companies that I did just to support the different populations. For example, physicians and nurses were not allowed to work for a company that touched the plant. So I had to start a separate medical practice for them so that they had control and weren't actually touching the plant directly from a legal standpoint. And then the gentleman in Australia approached me in, I want to say late 2000. I spoke in Australia in 2014, and they became familiar with my work, and we collaborated on starting Zelda Therapeutics, which has now, we did preclinical research on the 3 major subtypes of breast cancer, utilizing an extract that I had made here at Aunt Zelda's in the US We did it in conjunction with Complutense University in Spain, funded by Zelda Therapeutics, and published to great feedback from the public and the medical and scientific community on that. We did research in insomnia, utilizing a formulation that I had created at Aunt Zelda's. And because we had collected all this data around patient usage, when it came time to do a clinical trial, which of course is quite expensive, which is why everyone doesn't do it, we had enough empirical data to justify the expense of running a clinical trial on the formulation because we already knew that it was working. And sure enough, it has worked and is now being released into the market. Late last year, we merged with Alira Healthcare out of Pennsylvania to become Zelira Therapeutics. And I have stepped down off of the board now just as an advisor, so that they've got a great team and they're doing fantastic work, so that I can continue to focus on my software and the platform to make it available more globally to the medical community. So, it was kind of an inadvertent going from making carrot cake in my kitchen to running multiple global organizations with licenses in South Africa and moving into Brazil and Australia, etc.
Now, a lot to unpick there, and I certainly want us at some point in this interview to touch upon the studies and the clinical trials that you've run, because I think that is particularly pertinent in this space. But another thing you mentioned was around the platform where you're aggregating data. Can you tell us a little bit more about that and how the data that you're collecting and using within this platform can be used? Is it more for clinicians? Is it for patients? Is it for both?
It really is for everybody in the life cycle of the medicine. If I can take just a minute to unpack that for you, I will here. The acceptance of cannabis as a medicine must be guided by the physicians, because that's the only way we're going to have global acceptance, that we're going to change laws and policies around the world. Patients do a lot to bring it to the forefront and attention, but there's going to be so much fear around the plant unless we can get the medical community on board in a substantive way, and not a limited group of physicians, but mass acceptance and adoption of cannabis, just like any other medicine. So the platform is designed with multiple different pieces to it. So part of it is the physician is able to utilize the data of what we've already been doing, treating patients all these years, to make an initial target recommendation to a patient on what to use and how to use it. Now, part of it is rules-based, so that there are some ways to predict what's going to work and what's not. And we're, utilizing algorithms that keep getting smarter and smarter in the platform for those purposes. On the other hand, patients are able to give their physicians much more honest, thorough information, because we're collecting about 300 data points going into it from each patient, plus then following through with scans, labs, blood work, scales that are whatever appropriate for the objective of treating the patient. What this also does is it then gives a closed loop set of products for the patient to select in their area that are available based upon the lab results associated with those products, to determine whether they're appropriate for what the patient should get based upon what the physician's recommendation. In the past, so much of the pain point, and that I hear from physicians and nurses or other caregivers, is that the recommendation is made as to, the profile of the medicine and the dose that the doctor wants the patient to use. And then the patient gets to a dispensary and ends up with something that's completely inappropriate and not the right product to match what they want them to be taking. And as a result, the patient then tries it. They say, I used cannabis. It didn't work for me. It failed. And then they stop wanting to pursue plant medicine. So that's really catastrophic for the healthcare system and the widespread adoption of cannabis. So as a result, we help people by giving them a vetted, curated set of products to see based upon the COAs, so that they can see what's going to work for them. So that If the physician says, I want you to use a sublingual and I want you to have a 1-to-1 ratio of THC to CBD, I want you to start out low and titrate up to 10 milligrams of each, since it's a 1-to-1. And I want you to take it in 2 separate doses during the day, etc. Okay, that would be a very typical sort of, and I want it to have beta-caryophyllene and limonene in there. All right, that would be a fairly typical recommendation that a physician might make to a patient. The way it is without our system is the patient then goes to the dispensary and oftentimes ends up with a gummy bear or a chocolate or something that's not correct for them to be using. With our system, it will, when the patient looks at the products that are available in their area, it'll only show the products to them that are sublingual, 1-to-1, or that could be used for 1-to-1, have a low enough concentration that they can safely and accurately get to 10 milligrams in a 5 milligram dose and a 5 milligram dose, instead of giving them something that is so highly concentrated that it would be quite difficult to accurately get them to a lower dose, initially anyway, without experience. So this does things to help the cultivators to know what to grow because they know what products that people are going to be using. It lets the delivery services or dispensaries know what products to have on their shelves because they know what products that patients are going to be ordering. And unlike the adult use market, with the medical market, patients are going to order the same thing over and over again on a regular recurring basis because of the way dosing works. So if you give a patient a 60, 90-day supply of medicine, they're going to need a refill every 60 to 90 days, and they're going to want the same thing. So this takes a lot of the guesswork out of it for dispensaries to know what to have on their shelves. And also it allows the growers to know what they're going to be able to sell for the market beyond just, flowers. And, so much of the dispensary world right now, you go in there and it's all about, the highest THC for the lowest cost and, what's the newest and greatest flavor of the week. And that's just not medicine. That's not how medicine works at all.
Well, following on from that, and something you mentioned that Johnny wanted to bring us back to, the clinical trials, and perhaps a point that we've had with other guests. We've had Professor Duddy Mary talking about this. And what I want to understand is when you're going for these very targeted treatments using cannabinoids, when you're using it to help people with cancer problems, it seems like you need very specific cannabinoids within the medication, and those aren't necessarily the major ones. So when you're taking your products through to clinical trials, are you taking your extract and measuring not just the THC and CBD, but also the minor cannabinoids and the terpenes in there? Does that not make it very difficult to create something that's standardized for the level required by a clinical trial?
That's a very good question. So Deddy is a friend of mine, and let's keep in mind that he is a bench scientist. He works in petri dishes and on mice, not on humans. And over 80% of all drugs that are created do not make it from the bench through human studies. All right. So a lot of it's a bit more like a party trick and a lot less like what's going to be applicable for humans. And the scientists that I work with would caution with great gravitas, thinking that what works at the bench or doesn't work at the bench has really much of anything to do with what's going to work in humans. Now, we have found in our experience in treating patients that if we have a certain profiles within a certain range, we're going to have a better success rate than in others. And it also has to do with the way that the medicine is actually processed and manufactured as well. So it's not just the profile of the plant, it goes all the way through and how it's actually made. The minor cannabinoids, what I always say is we need to use full spectrum medicine. It is not important to get this down like a pharmaceutical where we're down to a single molecule, because the healthcare system has failed in so many ways because of these single molecule medicines. And by keeping it full spectrum, we can know the dosing of the major cannabinoids and major terpenes, and the minor cannabinoids in there need to be there, but it isn't as important that we know every single solitary component of them. There might be 500 different components in a plant. And I think it would be unrealistic to think that we would be able to utilize that information in any kind of a realistic way in formulating and creating medicines. They're just too complex. So we don't know what the key log is yet in treating diseases within the plant, why one medicine works and another one doesn't. However, we do know that if we keep it within the full spectrum, and what I mean by full spectrum is truly the same profile that's in the flower stays within the final product without adulteration beyond removing waxes and the natural occurrence of decarboxylation, where certain terpenes are so volatile that as soon as they hit the air, they disappear. So really, does it make sense to even test that in how it's going to work on treating humans if it is so volatile? It doesn't make any sense. I don't concern myself particularly with knowing every single component that's in there because I don't think it makes that big of a difference. At least in the tens of thousands of people that we've treated over the years, we haven't seen that it makes that much of a difference. I do know that when we're treating cancers, oftentimes we're using plants that come from genetics that have higher levels of limonene and linalool and beta-caryophyllene and more minor of the myrcene, very low levels in many cases of the alpha and beta pinene, in some cases higher alpha pinene. But we do know the profiles in general that not only work on helping to kill the cancer cells in a petri dish and in mice, but also seem to be working in helping patients to have better outcomes. And that's good enough for me because we're talking about whole plant medicine. We're not talking single molecule. There are a lot of people that are going down the single molecule route. I just happen not to be one of them. I think that that's a disaster. People probably couldn't eat enough poppies to die, but look at the opioid crisis. People couldn't probably eat enough willow bark to die, but look what happens if you eat too much aspirin. So we don't want to do the same thing with cannabis. They're not necessarily going to have deadly outcomes, but certainly quite uncomfortable. I mean, there is no market right now. You don't see a street market for Marinol, even though it's THC, because it's so uncomfortable on its own. So, I'm just not worried about that.
That makes sense. I was more thinking about it from the angle of how do you make your clinical trials palatable to physicians who are used to seeing single molecule clinical trials? How do you get them comfort with prescribing these? Because I totally agree with your overarching point that when you strip out to a single molecule, it doesn't seem to be as effective for patients. And you've got more experience of that than probably most people. But how do you get physicians to see what I would imagine is quite a new way of looking at clinical trials if you can't account for every substance within the mix?
The reality is when you look at pharmaceuticals, they're not as pure as you think. There are other things in there, and they below certain levels, they do not even have to be listed or accounted for. So it's a bit of a myth that it is just the single molecule and that there's nothing else in there. There's all sorts of other impurities and additives within. But the way that we have them adopt it is we start out by approaching the medical community that is more open to nutraceutical and inclusive medicine. So we've been working with a lot of functional integrative physicians, doctors of osteopathy, who are going to be more open to plant medicine than your standard, like, for example, it would be rare to expect an oncologist, though I am working with oncologists, quite a few of them, but it would be unrealistic to expect a general adoption of cannabis-based medicine for oncologists other than as something for the side effects of the traditional allopathic treatments. However, once patients start having outcomes that cannot be explained simply by the allopathic treatments, these physicians in many cases become quite curious to know what were they using and how were they using it and why did it work? And so it opens an opportunity. So part of it is encouraging patients to stop using cannabis underground and start having open and honest conversations with their physicians about what they're doing. Besides the fact that it's safe, it's not safe to not inform them based upon some of the pharmaceuticals they might be giving you with the drug-on-drug interactions. But it's also going to help for the adoption of less traditional medicines. Well, actually traditional before, Bayer introduced aspirin. So this is actually, plant medicine is the more traditional form of medicine than the single molecule. So it's a part of it's awakening that memory and also doing safety studies and showing that there is relative safety with cannabis-based products, so doctors don't have to be quite as concerned about adverse effects from them. It's all about education. I spoke last year at the International Cannabinoid-Based Medicine, what was it, ICDP, pharmaceuticals, whatever it is. It's a conference that takes place each year. It's an international conference on pharmaceuticals. And I delivered the paper that we had done on breast cancer. And they invited me back I was the only one at the entire conference last year, other than a speech that Ethan Russo gave about plant medicine that actually spoke about formulating and doing trials with full spectrum instead of single molecule. And they had invited me to come back and speak. And I said, well, there's really no point unless you let me talk about nutraceuticals. So I put together a panel and the three of us delivered a 3-hour workshop on the value of nutraceuticals and whole plant medicines in treating various diseases. So it's event by event, it's conversation one after the other. It's showing data, it's proving safety studies that will really, all of those things to help to ameliorate the fear that physicians have. The other thing is, there's this continuous mantra out there that, cannabis, we just need more studies. We need more studies. And it just makes, it's mind boggling to me because there has been no plant in the history of the world that has been studied more than cannabis. I mean, just do your PubMed search and it's ridiculous. There are over 10,000 studies on it compared to, I think Ritalin had 400. The reality is, though, a lot of them are studies that are designed to disprove its efficacy because that was the only kind of funding that was available for a long time. So it's a matter of getting some better studies out there and just education and doing podcasts such as this to help physicians to accept it.
And on the topic of studies and trials, sort of, you were talking before how you had a ream of studies and then took them through to clinical trials. Now, this is very pertinent at the moment in the cannabis space, and no doubt there will be a huge amount of organizations that are looking to take their studies to clinical trials. Could you just give us a little insight into the process of taking a study through to trials? We would love to get a bit of a lens in on sort of how you went about this.
Well, fortunately, I didn't have to deal with the day-to-day of clinical trials because we had a brilliant team with experience doing it. And anybody that says, I hear a lot of times that people say, oh, yeah, we're doing a clinical trial. And I'm thinking, yeah, right. Clinical trial is something where you have a very specific skill set of people with tools to use for monitoring. And has to be quite objective. It's not something that you do to prove out your theories. It's something that you trust to a group to do to prove out your theory, and they have no skin in the game one way or the other of whether it's accurate. So the first thing that we did, for example, on the insomnia formulation, because it is quite expensive to do these studies, Zelda Therapeutics, which is what we were at the time that we were doing the studies, we had filed patents on the formulation that I had created at Aunt Zelda's for insomnia. And once we had that, investors are going to be much more likely to be interested in participating in something like that because it is expensive. So you have to raise the money to do these studies because it can cost many, many millions of dollars to do any kind of a clinical trial. We then partnered with a university a hospital and a group of people that were expert in running clinical trials. And I remember sitting and working on the dosing and figuring out, okay, this is the dose range that we should start with and we should have as our initial target. And then we figure out what is our cohort, who is the group that we're going to be testing it on. Can they have used cannabis before? Do they have to be completely cannabis naive? Do we let them know it's cannabis before the study? I mean, all of the different things you have to design into your study initially, so that when you're recruiting patients, which is the most complicated part of any study, is the recruitment, you make sure that you're testing the right people, asking the right questions. You then have to formulate in such a way where you have a placebo that they don't know that the placebo is in fact one, so that you can get valid information. This is a lot more complicated with cannabis because it has very specific effects in smells and tastes, etc. But it can be done. And so you formulate that, you set your time frame on your criteria for testing, and you begin the testing. And once you have them go through one cycle, you then switch it after the clearing process. You then switch it to the other formulation, one with and one out, whichever order that you give it to them. And then you compile and analyze the data on the results. And it's very methodical, and the same way that you would do a study with any other drug trying to get it to market. The difference is we're not concerned about FDA, because the FDA is not necessarily the most realistic route for getting drugs to market, cannabis-based products to market. So we're introducing to market as nutraceuticals, that have been tested and can make claims. I hope that answers your question.
Yes, I think that's a pretty comprehensive answer. And also a right direction, because ultimately you can only start building comfort when you've got that ability to make claims. I think we've only got time for a few more questions, and I wanted to go slightly less technical and slightly more personal, because something you said about the education piece and the utility of being on podcasts and doing education made me want to bring up, of course, your starring role in the film Weed the People. Now, for our listeners who don't know about this is, I don't know, probably about 3 years old, and follows Mara and a cohort of patients as they start using cannabis-based medicines. But I think what it meant for me was it was one of the first times that medicinal cannabis had been shown not just in a sort of pain-relieving way, not to say that pain-relieving is not an important medicine, but something that showed that cannabis and the endocannabinoid system has far more potential for medical therapies than most people would have given it credit for 10 years ago. And I just want to ask you, Mara, what's it like being a cannabis education celebrity, and how can you use platforms like this podcast to get the message across?
Wow, celebrity, that's funny. Anybody that knows me, I'm just kind of a no high, no buy sort of person, just give me the facts. I'll tell you a story. So yesterday I had the privilege of doing a 2-hour brown bag with a group of master's degree candidates at the University of Maryland School of Pharmacy. These were students that were looking for, they're in a master's program on cannabis medicine through the pharmacy department. And they just had loads and loads of questions for me. It was packed, my session. And several of them wrote to me, and they had seen Weed the People, and it was their first eye-opener to the possibilities of cannabis. And in some cases, they changed their career path because of having seen that documentary, which was quite fulfilling, of course, for me to know that my allowing a camera crew to follow me around for 5.5 years is going to have downstream positive effects for the healthcare industry. I don't consider myself anything other than just a person that has been asking the same questions over and over again and looking for the answers from the beginning without pivot. The one thing I have never done is pivot. I wanted to solve how dosing worked. I wanted to figure out how to make this wonderful medicine available for more diseases. And I wanted to have physicians feel comfortable doing it. And so whatever was necessary to reach those objectives, that's what I've done and continue to do. The documentary, certainly there are moments in it that are a bit cringeworthy for me. And just because, it's difficult to see yourself on the first time I saw the film, I was at South by Southwest in Austin, and I was watching it and it was featured there. And seeing myself on this big, huge screen and following the work that I had been doing, I just thought, oh God, if I'd known, I wouldn't say that now. I wouldn't do that now because I know better. So now that I know better, I do better. I think that having the opportunity, if it opens a door where somebody's interested in asking me questions, and if they pay attention to the answer, then it was worth it. I love having the chance to teach, and I love when I hear my words come out of other people's mouths, because then I know that I've been successful, and there will be a time that'll come when I can actually stop and enjoy my life a little more instead of having to constantly push forward to get this plant accepted.
Well, I think we can say without a doubt that we know you've been successful, and this podcast certainly was a success. So thank you for your time here with us.
It's my pleasure. Thank you.
Well, listener, we hope you enjoyed that interview with Mara. And if you did, please do support us on the Professionally Cannabis podcast. Oscar, how can our listeners support the pod?
Well, they can send 1/10 of their field, their first son as tribute, or 1,000 silk rugs. Barring these preferred bits of support, we will also accept likes, comments and shares with friends and colleagues.
Absolutely right. Absolutely right. And listener, please do check out our back catalogue as well. We have a whole array of interviews ranging from those in the medical world, the business world, the science world and the policy world. Lots of really engaging interviews there, and we think you really, really will enjoy them. But for the time being, thank you so much again for tuning in, and we, look forward to receiving your silk rugs. Bye now.
Love, please take me above, take me with you.